Assalamu alaikum, everyone. Am I audible?
Walaikum salam. Yes, you are audible. At least you are audible to me. I don't know about others.
I think I'm perfectly audible to everyone else as well then. Okay, everyone. So this is our last session before Eid, inshallah, inshallah. Let's see how much we can cover regarding the posterior cervical fusion of C1, C2, and let's see if we can get to the occipital-cervical fusion as well. Otherwise, we can continue it post-Eid, inshallah. Dr. Itzaz, we are already live and the recording has started. So I'm muting myself. And you can take over from here.
Okay, thank you. Assalamu alaikum and good evening, everyone.
Alaikum salam.
So, thank you. Again, we are here with it's not a last session from my side because still there is a lot of things are there in the upper cervical when we will talk about the craniovertebral junction. So today we will try our best to conclude this session. That is a very important one. That is the posterior cervical fusion C1, C2. Most likely not means definitely. This one approach definitely it will come in the exam. Those who are going to the exact exam, because it's a very good and standard approach. So let's start. So what's this one? Anyone who can interpret and name this one? Because first we will go through that. What is the indication of C1 tissue fusion and what are the our area where we can do it. When we say C1, C2, it means definitely mostly post-traumatic patients we can apply the C1, C2 fusion technique, but not only the trauma patient, most of the time in the trauma patient, but it could be the tumor patient, it could be also the craniovertebral junction anomalies. So there are a lot of indications of C1, C2 fusion, and it is applicable to a lot of pathologies there. But we will discuss the trauma today. When we'll see that C1, C2 fusion, you can apply the same technique with all the patients, but application will be same as in the trauma, in the tumor, in the craniovertebral junction, but the indication is different. Okay, so what you see here, anyone?
Assalamu alaikum, sir. I'm Dr. Javeria. I would like to give it a go. I think this
Yes.
is a C1 fracture. It is showing the Jefferson type 1, in which the posterior arch is like fractured, or the anterior arch is fractured. Then there is oblique as well, and in which both posterior and anterior are like fractured. This is Jefferson 3. This is a classic burst fracture in which there are 4 points. And then Jefferson 4 is the lateral mass and the comminuted medial tubercle comminuted fracture.
Okay, what is the Jefferson 3?
I didn't get that.
What is Jefferson 3?
Jefferson 3 is the classic 4-point burst fracture in which the posterior and anterior arches are fractured at on both sides.
On both sides. So in this figure, which one is the Jefferson 3?
This one on which your pointer was, a center one.
The center one is Jefferson 3. So this is Jefferson 1, this is Jefferson 2, this is Jefferson 3, this is Jefferson 4. Am I correct?
Yes. The other one with the lateral mass is also the 4.
Yes. This is Jefferson 4. That is called the community fracture. Bus fracture when bilateral rings are involved. Excellent, Dr. Javaria. Thank you. So this is the classification of C1 fractures. That is called the Jefferson fracture. It has about 4 types. So what are another classification of C1? Yes, Dr. Javaria.
It's a Lendl.
So how will you classify the Lendl?
In Lendl 1, there is either the posterior arch is fractured or the anterior, and 2 is the Jefferson 3, and 3 is this one with the transverse process of the lateral mass fracture.
Yes, in the Lendl there's a bit difference that it has only 3 classifications, 3 types, and the Jefferson type 4. In Lendl, the type 1, Jefferson type 1, type 2 will be included in Lendl 1. Then the Jefferson type 3, the Lendl 2, and Jefferson type 4, the Lendl 3. Thank you. So what is the presentation? What will be the presentation of these kind of fractures when the patient comes to you? And actually, first we should discuss the mechanism of injury in these kind of the patients. So what could be the mechanism of injury? Because they have all the different kind of mechanism of injury when you see. Can you elaborate, please?
I think it was anterior, posterior, and rotational type of injury.
It's very easy. This one, it's very easy. Look at here. Look at here. This is the anterior arch fracture, and Dr. Kingsley, yes, you raised the hand. Please unmute yourself and yes, please. You want to say something?
Yes, the dominant mechanism of this injury is usually axial loading.
Very good. During the axial loading is most likely the common in C1 type of the fractures. But we see when there is an anterior arch fracture, it means the axial loading with severe flexion will be there. Look at here. Because only the anterior arch is fractured. Why it's not moving? Only the anterior arch is fractured. So what happens when there is axial loading and severe flexion? Then the anterior arch of this one can be fractured. In the posterior arch of the C1 is fractured how? Contralateral to this one, opposite to this one. When there is axial loading and extension will be there. Severe extension, the posterior arch bilaterally or unilaterally fractured. Okay, what about this, you can say, the bus fractures? Bus fracture will be most severe axial loading. It can flexion extension, if there is combined, then can be anterior and posterior. What about lateral mass fractures? Yes. What about lateral mass fractures? Axial loading with lateral bending, lateral rotation is there. Okay. When we are doing the lateral rotation and there is an axial loading, then there could be the chances that lateral mass fracture will happen. Okay. Which joint actually it will prevent the lateral bending and lateral rotation? I'm seeing that Dr. Yusra is there. Dr. Who is there?
Ancovertebral joint?
Dr. Sana is there. Yes. Who is saying ancovertebral?
Ancovertebral joint.
Excellent, excellent. Yes, very good. Ancovertebral joint. It means when the ancovertebral joint is compromised, it has a lot of weight over there, burden, then it can compromise the lateral mass fracture. Okay. So this is about the mechanism of injury of C1 fractures. Now the presentation. What could be the presentation of C1 fractures? Yes. 90% these kind of fractures, they present only with the neck pain and restricted sometimes of the neck movements due to severe pain and spasm. Okay, just 5 to 10% patients they can present with the deficit. Why? because the deficit is minimized. Why? Because the canal is so large and huge, you can see that it can accommodate the injury, and there is a less chances of spinal cord injury. That's why the most of the time these kind of the patient when presented depend only the severe midline neck pain with the restricted some kind of movement. Restricted movements not because of the dislocation, it is just because of the muscle spasm. Otherwise, there is no anything here that can restrict the movements over there, except there is a you can say the bilateral the bust fracture is there or the lateral mass fracture is there. Then can patient have the restricted movement that is related to the fracture. Otherwise, there is no other cause of this one out of the instead of muscle spasm. Okay, so how we will deal this patient? Oh, sorry. How will deal with patients? Which kind of a fracture in this one that is unstable? Yes. Yes. Which fracture in this one will be
Type 3,
unstable? Type 3 is
type
unstable.
3, type 4.
Okay, and type 4, type 3. Bust fracture lateral mass is unstable. Again, there is only one indication of instability in this one. We can say that these are unstable, and that can go to the surgical intervention. Okay, so what is that criteria that can, according to that criteria, you can see that that these are unstable fractures. Yes, please. What is the criteria of most of the C1, C2 fractures? Yes,
Tal
Dr.
injury,
Sorry?
tal disruption, transverse
Oh,
internal ligament disruption.
excellent, excellent. Don't say first you said the cord injury, tal injury,
Tal, tal.
tal. Okay. The actual point is the tal injury, transverse atlantal ligament injury is there. If the transverse atlantal ligament is injured, then it means it is unstable and there is an instability. That patient needs, you can say, the fixation. How will you come to know that tal is disrupted? How will come to know that tal is disrupted? Yes, please. Anyone? Yes, Dr. Kingsley.
Okay, if there is a increase in the atlantoaxial distance, that the distance between the atlas and the dens. I can't remember the
Mhm.
dimension exactly. Or on MRI, if there is hyperintensity within the TAL, it suggests disruption of TAL.
And other one? How much
These are the
ADI
ones I
should
need to
be?
think about.
What is normal ADI? What is normal ADI?
I'm not sure.
Atlantodental.
I'm not
Yes.
sure.
Anyone else? Look at this picture. This is cervical spine X-ray. That is the lateral view. Normal ADI is 3 mm, less than 3 mm. That should be. They said that if there is more than 3 mm ADI, or some surgeons, some literature says that the surgical criteria is 5 mm. So the 3 to 5 mm. Okay, when there is more than 3 mm, then it means the transverse atlantal ligament is disrupted. Look at here. Uh, this ADI is increased. Look at here. And this is your tubercle. Little bit I draw this one. Sorry. Here it will be. We count this distance between the dense odontoid and anterior tubercle. It is increased. When it increased, it means the more chances are that there is incompetence of the transverse atlantal ligament. Transverse atlantal ligament is disturbed. Or Dr. Kingsley once said, then one is the ADI and second is the MRI. Which MRI sequence is most important? Yes. Which MRI sequence is most important? Okay. Gradient echo MRI, that is the most important one on that one sequence. When we say the radiology, first is that on X-ray ADI is increased, then there is a chances that that the transverse ligament is disturbed. Second thing, but who can interpret this X-ray? It is which view and what is the findings in this X-ray? Dr. Javiria, yes, I have one request from you guys, that most of the time when I came on Zoom and start to talk, less likely I see the chat. Yesterday, Dr. Kamal reminded me. That's why I am starting to see the chat today. But because it disturbs me, that's why I don't see. So anyone who want to talk, just unmute yourself and start to talk, please. When
Yeah, I'm realizing that every time you check the chat, it breaks your flow. So you
yes,
can continue, and anybody who wants to respond, they can just unmute themselves and respond.
okay. Uh, this is open mouth odontoid view of this one. You can see the open mouth screw. You can see this is the coronal section. This is the above, you can say the hard palate, and this is craniovertebral junction you can see, and this is the third C3 and this is C4. This is odontoid. You can see here. This is odontoid. This is C2. Okay. This is C2. This is odontoid of C2. And this is the body of C2. Okay. This is C1 that we call lateral mass of C1. These. This is line of vertebral bodies. Can you see the lateral masses of C1? They are a little bit displaced laterally out of the line over the C2. Can you see, please?
Yes, sir.
Look at here. What we call it?
Lateral mass overhang.
Lateral mass overhang. What is the second name of this one? Lateral mass overhang.
Lateral mass angulation.
Lateral mass angulation, lateral mass overhang. This is same thing. Rule of spans. This is the rule of spans. When the bilateral lateral mass of overhang of C1 over C2 is more than 7 mm, we count this overhang is the extra one. When it is more than 7 mm, that it means it is suggested that the transverse atlantal ligament is disrupted. So we have seen two things. One, that when the lateral masses of C1 or C2 overhang is increased, the rule of spans is more than 7 mm, then most likely there is a chance that transverse atlantal ligament will be disrupted. Or when the ADI is increased more than 3 mm disrupted. And the third thing that is we need the MRI. MRI is the definitive, you can say the measurement, the tool by which we can see. Otherwise, these are the crude methods, both the rule of spans as well as the ADI. Okay, so this is another picture that you can see. Which type of a fracture is this one? Except Dr. Javeria.
Yes, sir. Sorry, I didn't get it.
No, you will not answer this one. I said
Okay.
anyone else who can answer this one.
Okay.
Type
Okay.
3 Jefferson.
Sorry, Dr. Yusra, you are there? What are you
Yes,
saying?
type 3 Jefferson and
Excellent,
Lendl.
excellent. That 3 Jefferson is there. This is bus type of fractures, anterior and posterior arch are compromised. Okay, so this is just overview of this one. So transverse ligament is important. We see the transverse ligament. It is disrupted. It means there is an unstable fracture. Unstable fracture that should be fixed. That should go to the surgery. There is a controversy that some says, literature and surgeon says that wait for 3 to 4 months or up to 8 to 12 months. Hollow west collar should be applied. Then after that, go for the flexion external X-ray. If there is an mobility and stability, then fix. It is a long time of the duration. The patient cannot wait. Atlantal ligament is disrupted, and most likely the anatomical atlantal ligament is there. Disruption is there. It means it is definitive instability is there. Okay. So what is the types of transverse atlantal ligament disruption? What are the types of atlantal ligament disruption? What is the Dickman classification of transverse atlantal ligament disruption? These are the questions which came in the exam. So you have to be prepared about that. Yes, please.
Let me try.
Yes.
Okay, the classification, I think the name is Dickman's classification. So it depends on the anatomical location of the disruption. For type 1, I think it involves the ligament itself, while type 2 involves the attachment to the lateral mass. Type 2A, and then 2B, there is avulsion of the lateral mass of attachment of the transverse atlantal ligaments.
Okay, good. So there are two types of transverse atlantal ligament disruption according to Dickman classification. When there is an anatomical one, there is a type 1. Anatomical classification type 1 is the it shows the instability of transverse atlantal ligament. It will not heal conservatively. So again, that anatomical type 1 is subclassified into two types. First, type A, anatomical. Anatomical again subdivided into two types. The one that the transverse atlantal ligament is disrupted, but it is called the mid-substance disruption. Look at here. This is transverse atlantal ligament. This is odontoid. Posterior is attached to this one and the C1. Okay, look at here. So this is transverse ligament. When transverse atlantal ligament is disrupted at any side, not at the junction bilaterally, is disrupted or cut it down completely, that is called the mid-substance tear or mid-substance transverse ligament disruption. Look at this green level, this green mark there. This is mid-substance. It means at the mid of any between the 2 points of insertion, it is disrupted. So we call it mid-substance. Second point is that when transverse atlantal ligament disrupted is there at the level of transverse atlantal periosteal area, it means at the between this area, but there's no involvement of the bone will be there. Bone will not involve, but it is going out from this area, away from the periosteum. It is detached from the periosteum. That is called the atlanto-periosteal disruption is there. Okay, transverse atlanto-periosteal disruption of transverse ligament. So these two types, they are actually, it is called the anatomical types. What is the second type? That is called the physiological type, in which what happens when there is a bony tubercle is attached, the transverse atlantal ligament is detached with the bony tubercle is there. There's also a bony tubercle detachment is there. You can say the avulsion is there of the bony tubercle. So that is called the physiological. Why in the type 1 that the transverse ligamental is unstable? Why in type 2 is not unstable? Though in type 2 it is also avulsion is there. Transverse atlantal ligament is disrupted again. It is separated from the insertion point, but it's not unstable. Why?
Because no bone is there to provide fusion in type 1.
Excellent, excellent. This is the reason, that's why we call it type 1 is there, because there is a bone attachment. So bone can calcify, then it can attach that one. When it is there's no any bone, so there's a very it's difficult that it can heal. This is the not only this one, any ligament that is disrupted and there is no any bone there, it is very difficult chance that that ligament will heal. That's why we count that type 1 anatomical type is you can say it is unstable. So in C1 fractures, we will see that what is the status of transverse atlantal ligament is there. If it is disrupted, it means we will consider that fracture is unstable fracture. Most likely type 3, that is the burst fractures, and the type 4, that those are the comminuted or lateral mass fractures. They are you can say the unstable fractures. So how will you manage this case? Uh, the unstable fractures will be managed conservatively with the external immobilization. What mean by external immobilization?
Dr. Itzas, we are losing your voice.
Now it's clear.
Yeah, it's clear now.
So external immobilization for the type 1 and type 2. Jefferson type 1 and type 2 or Landel type 1. Mostly they are stable fractures and they will be managed conservatively with external immobilization. So what's mean by external extraction? With the help of the collar. Most likely the Philadelphia collar is we prescribe that there should be, we advise the Philadelphia collar. They say that Hello West should be there, but it's very difficult to nowadays. I haven't seen any patient that who wear that one. Okay, so for 8 to 12 weeks, for immobilize the C1 C2. And second one is there unstable fractures are there. So how we will manage that one? What are the options? It means we are going for the surgery. So what could be the surgical options in these patients? Yes. Okay. Yes, Dr. Yusra, you want to say something?
Yes, we will do fusion. If C1 is fracture, so OC fusion.
Okay. And what about others?
Like if C1 is a stable fracture, no, for unstable fracture, sorry, can you repeat your question, please?
What we'll do, surgical options. What are surgical options in unstable fractures, in C1 fractures?
C1, C2 fusion and OC fusion. depending upon
by
the
OC fusion?
occipital bone and C2.
Okay, you say that occipitocervical fusion is there. Yes, you're
Yes.
right. These are called excellent. Thank you. You are right. This is called fusion technique. When we are doing the fusion technique is there. When we are doing the fusion technique, we have two options. When there is a unilateral ring of the C1 fracture is there, then unilateral ring of C1 there, or only the anterior arch is there, then we will do the C1, C2 fusion. But when there is a multiple ring fractures are there, our posterior arch is compromised. Now it means we cannot do the C1, C2. Now we will do craniovertebral junction fusion, like you can say the OC fusion, what Dr. Yusra told us. So that is the occipitocervical fusion. This is called the fusion technique. When there is a single arch is involved or anterior arch is involved, ligament is disrupted, that is less likely. We will go for the C1, C2 fusion. When the multiple arches are fractured or posterior arch fractures there, then we will go for the OC fusion. That is called occipitocervical. But when there is no fusion technique is there, we are not going for the what you can say the orthodoxy. Okay, so what are the options then? Yes, yes. What the other options? Is there any option of posterior apart from the C1 C2 fusion? Then we have two options. One, either we have to go for the transoral screw or plate screw placement is there. Okay, transoral approach is there. That is very difficult. Usually we don't go. And second, we have to go posterior C1 screw placement only. Okay, so there are two options. One is the fusion technique, that is the C1 C2 fusion or OC fusion, occipitocervical fusion. Again, if there is not there, then posteriorly either we have to place the posterior C1 screw placement, that is called the lateral mass screw placement are there, or we have to place the transoral, we have to go the transorally screw and plate placement over there. So there are two techniques. So most likely we do actually the C1 C2 fusion or OC fusion. Okay. So let's come to the C1 fractures. We will see that how we are going to C1 C2 fusions. What are the C2 types of fractures are there? We will go fast now because we are being late. We have 25 minutes, so inshallah we will cover it. So C2 fractures, there are two types. One that is related to the odontoid. You can see there are three types of odontoid fractures. We will consider it four when there is a type 2 subtypes will be there.
Dr. Itzaz, we keep
So
losing
what
your
is
voice in
the,
between.
now it's clear?
Yeah, it's clear, but I think you move away from your mic or something else happens because we lose your voice in between and then it
I'm
comes back normal.
very close to my laptop. I'm very close to my laptop and attached to the laptop. I don't know why my voice is being disturbed.
Okay,
So
okay.
when I'm at my home, the net is, I don't think why it's not clear. So but when I'm at my clinic, so the internet is good. So now it's clear.
Yeah, it is.
So what are the classification? What is the name of classification of odontoid fractures?
Anderson classification.
Dr. Yusra, Dr. Javeria, Dr. Kingsley, you are exceptions, so you will not reply now. So yes, Anderson classifications. Okay, that is called the type 1, type 2, and type 3. Type 1, that's just tip of the odontoid is fractures. Type 2, when the odontoid base is fractures, and type 3, when the some part of the body is also involved in this one. Out of these all types, which type is unstable fracture? Yes. Yes, please.
Sir, type 2.
Type 2. Excellent, Dr. Sana. So type 2. Why the type 2 is an unstable fracture?
Sir, because neck attached to the body and there is a less supply, blood supply, difficult healing.
Very good. Very good. That's why this is the reason that why we consider this as an unstable fractures. Okay. So this is the you can see the odontoid. And second classification of the fracture of C2 related, that is what is shown here. Yes, please.
Classification.
Yes. What is shown here? Dr. Sardar is saying something. Yes. What are the fractures? These are the fractures.
Sir, hangman.
These are hangman fractures. Excellent. These are called hangman fractures. So what is the classification of hangman fractures? Yes.
Assalamu alaikum, sir.
Yes. Walaikum salam, Dr. Mustafa. How are you?
Alhamdulillah, sir. Sir, Levine classification or modified Effendi system and the Francis grading system, sir.
Levine classification and Francis grading system. Excellent. So I will not go into detail. Thank you, Dr. Mustafa, for helping me. So what is the Levine classification? Go through this one. Just tell me what is unstable fracture, the Levine, then we will proceed further.
Sir, in Levine type 2A, we do the hollow west immobilization, and Levine type 3, we do the ACDF, sir.
So what are the unstable fractures in this one?
Type 2, 2A and 3, sir.
Type 2, and 3. Okay. Most likely the type 2A and type 3, these are unstable. Type 2, sometimes with the help of conservative management, it heals. So what is the difference between these? We are not considering the type 1 and type 1A. Why? Because these are just the linear type of the fractures, and their first tell me, what is the hangman fracture? What is the definition of hangman fracture?
Fracture of the second cervical vertebra or axis. It's
Pars interarticularis fracture of C2.
Also, yes. Yes, Dr. Isra, complete your definition.
It is the pars interarticularis fracture of C2 and second. Yes. And subluxation.
It's unilateral or bilateral?
Okay, bilateral pars
fracture will be unilateral or bilateral?
Bilateral pars fracture.
Bilateral pars interarticular fracture plus subluxation of C2 over C3. That is the definition of hangman. There are two things. First, there should be the subluxation, and the pars articular should be bilaterally fractured. Okay, so bilaterally pars fractures and then subluxation. Type 1A, there is only a linear fracture over pars. In type 1, there is no subluxation, that is less than 3 mm displacement there. In type 1A, there is a fracture is also going to the foramen transversarium, okay, transverse foramen, that involving there. So this is the difference. In type 2, there is a fracture over there, and there is a disc disruption will be there, okay. That will be disc disruption in type 2. That is the start from the distinguished point from type 2 and others one. and the displacement will be more than 3.5, and the angulation, it's not too much important in type 2. The displacement is significant in this one. When we talk about type 2A, that is oblique fracture, and that is very unstable fracture. What is the difference in between these type 2A and type 2? That the angulation is more in type 2A, that is more than 10 mm or more than, you can more than 11 degree or more than 10 degree usually something. And second thing is the oblique fracture. Okay, but subluxation will be similar to that of type 1A or type 1. That is like this one. Subluxation is less than 3 mm, but angulation is more. Look at here. There is no any subluxation. There is a minimal, but angulation is more. But what about type 2? The subluxation is more, but angulation is less one. So this is the difference between one. And second difference, as is the oblique fracture is there, unstable fracture is there, associated with disruption will be there. So we cannot apply cervical traction in this one. It will increase more angulation. We can apply the traction over here. Okay. What about type 3? Type 3 is type 2. That is type 2. Look at here. That is subluxation is there, and this one plus disruption will be there, plus posterior C2 arch will be free. Look at here, this arch is free floating. This arch will be free. Posterior arch of the C2 will be free. There will be disruption like same like this one, and subluxation will be same, and there will be the disruption of the facet joint. So this is type 3. That's why these two types, mostly type 2A and type 3, will be considered unstable fractures. And type 2, when there is a transverse ligament is disrupted. So got it? So
Yes,
these
sir.
are the Levine classification. What about the Francis grading? It's the grading. It's not a classification. It just tell the grading. So how many grades are there?
5, sir.
5 grades. What are those 5 grades?
In type 1 and type 2, is less than 11 degree, and grade, type 2 greater than 11 degree, but in both of them, displacement is less than 3.5 mm. And in type 3, it is less than 11 degree, and type 4 greater than 11 degree. And in both type 3 and type 4, there is displacement greater than 3.5 mm.
So what's mean by displacement?
The displacement means the movement of the C2 vertebra in front alongside of the type 3 cervical vertebra.
Okay. So this is the displacement. Okay. You are saying that the subluxation is the displacement. So you are right, Dr. Mustafa. In type 1 and type 2, there is only the displacement is counting. And second thing, the angulation is less than 11. In type 1 and type 2, the angulation is more than 11. But when we talk about in type 3 and type 4, there is same angulation less than 11, angulation is more than 11. But there is a one thing that is you can say that is added. That is called the displacement body ratio. That is called displacement body ratio. That will be the 0.5 cutoff value is there. If the displacement body ratio is less than 0.5 mm, that is in the type 3 and type 4. But when there is a displacement is body ratio is more than 0.5 mm, that will be considered in type 5. So this is the difference in type 5 and type 3-4. In type 3-4, the displacement body ratio will be less than 0.5 and displacement body ratio will be more than 0.5. How will count? How will count that displacement body ratio? Body of C3. This is the body of C3. Look at here. The width of the body of C3, it will be calculated. Then displacement means, look at here how much it is displaced. Look like this one, how much it is displaced. We will draw a line from here. There are two draw a line from here and draw a posterior line from here. Posterior part of the inferior, you can say the end of posterior end plate of C2. This is displacement. This is called displacement. You can also calculate the displacement from here, but it's a rough method from here, how much it is displayed. Okay, so this is displacement. We will divide this displacement with the body. When this ratio is less than 0.5 mm, then it is type 3 and type 4. Then if the ratio is more than 0.5 mm, then it is type 5. Okay, so in this way we have completed these types, but most of the fractures so now come to the what is the techniques, different techniques we are dealing with that one. We have discussed that the standard one, that is C1 C2 fusion, and second is that so we can go the transferally when the C1 is there. But odontoid fractures, odontoid compression screw we can apply. But when there is a transverse atlantal ligament is disrupted, remember one thing: odontoid compression screw will be applied only one condition, when the transverse atlantal ligament is intact. When the transverse atlantal ligament is disrupted, odontoid compression screw is contraindicated. Then we have to go for the C1 C2, again fusion posteriorly. Okay, and second is the C1 C2 fusion. OC fusion we have seen, occipitocervical fusion indication. But when we talk about the craniovertebral junction fusion or C1 C2 fusion, mostly actually we have two type of the techniques. Okay, one is called the Goel technique, and second is called the transarticular technique. Okay, one is called the Goel technique, and second is called what we call? Yes,
Transarticular technique.
transarticular. Who gave the transarticular technique? This is transarticular technique. Who gave the transarticular technique?
No idea, sir.
Who gave the Goel technique? Goel. Who gave the transarticular technique? Not transarticular. Magrel gave us the transarticular technique. So there are two techniques of C1 C2 fusion. So let's see what's the difference between these two. So actually, in transarticular technique, why I'm missing my pictures? Why I missed? Why I missed? Sorry, I missed that one. Just I'm telling you here. Okay, I missed that one. In transarticular technique, the Magrel says that he placed only, you can see this, the screws over there. There is no any rods are there in the C1 as well in C2. That's why it's called the transarticular technique is there. There is no any rod fixation in that one, in the transarticular process. How it does, and it does in the facet joints in this one. Look at here. What happened at the level of C2? At the level of the entry point is C2. Only single screw will be placed bilaterally from C2 to C1, and bilaterally from the right side and from left side. No separate screws in this one. So look at here. This is the entry point of this one. Made two lines. What will the trajectory? And trajectory will be towards the superior side, and you can say some says that towards the anterior tubercle most likely. Okay, that's like superior above. Anterior tubercle is little bit anterior and superior is there. So actually there is a one screw that is entering into the C2 and going with the help of facet joints towards the C1. That is called the transarticular. Why transarticular? Because that is the articular joint is there, that superior articular facet and inferior articular facet of C1 and C2. It is passing through this one and it causing the fusion or fixation is there, but there is no rods are there. Okay, so this is called the transarticular process of this one. So how it do? Actually, it does with the help of fluoroscopy. You need the fluoroscopy thoroughly. One, this is the entry point of this one, but first you have to draw a line from here while in the X-ray and in the, you can see the CT scan, that what will be our trajectory. This will be our trajectory. A line will be drawn and that line will be targeted over there. Okay. Then after that, how this line will be drawn, the incision is below to this one. There are two school of thoughts and two that one, either one in the that is the you can say the open technique, open directly. You have to open the C1, either you have to give the incision downward. This incision is not to do the screw for this one. This incision is just to get the angulation for the line. This line, look at here, this line. Okay, to make this line, we will place a wire there at that placement. Okay, then drill that area with only 2 mm. After drilling of the 2 mm, just pass the screws vertically above and towards the anterior tubercle. Okay, anterior tubercle, this one. This is called the transarticular technique of Magrel. What is the drawback of this technique actually? That there is the mobility will be compromised because the joints are fixed again. Second drawback technique is there. Thoroughly we have to use the fluoroscopy. Most of the time we don't have that one. Third drawback is there that there's a chances of vertebral artery injury in this one transarticular. Okay, this is called the transarticular technique. Step by step we will discuss separately inshallah again because I know that you need. So this is the trajectory of this one. Anterior cortex of the C1 tubercle, entry point will be this one, and then targeted will be the anterior tubercle of this one. This is the entry point. What is the Goel technique actually? Goel says that he is not putting the single screw. He is putting the C1 screw separately, either in the C1 lateral mass or the C1 posterior arch is there, and C2 separately. That is called the Goel technique. It means C2 screw will be placed separately in the Goel, C2 both. C1, we have two options, either just below to the C1 arch, posterior C1 arch will ronger that C1 and then will place in the lateral masses, or directly at the mid of the C1. I'm going backward. You have to place the screws bilaterally in C1 and C2. Here also a screw will be placed. There are two school of thoughts. This is C2 posterior arch. Directly at the mid of C2 will be screw placed. There is a one option. But we have to know you can say the normal anatomy of vertebral artery, because in C1, C2 fractures, usually we do the CT angiography or MR angiography. That will help us that what is the actually the direction of vertebral artery. when we are placing directly over the C1 arch posteriorly, then there are chances of vertebral artery injury if there is a vertebral artery just coming down and posterior to this one. Okay. Second option is that we are not directly placing the screw over there. Here we are drilling this area. We are drilling this area, lower part of the C1 here. Then put the screw in the lateral mass of C1. Okay, not directly placed. This is one option for C1. And the Goel says when we talk about the C2, we have three options for the C2. 2 is the more common, and the third one is less common. What are the three options for C2 fractures in the Goel technique? Goel says either you have to place the screw transpedicular. This is the transpedicular screw. The screw is going to the pedicle, most likely. That is from lateral to the medial. This is the lateral mass, and this is the pedicle. The Goel says then we are putting the screw in C2. We have three options. Either in the transpedicularly we will put the screw, either in the lateral mass, that is called lateral mass screws. Okay, either you can say the translaminar screws are there. There are three options when you are putting the screws in C2. Translaminar is less likely common, but so C2 pedicle is C2 screws can be put it in three sides. One as the transpedicle, lateral mass, or you can say the translaminar. So what the Goel is doing, so look at here, this is C1 screw. Okay, where the C1 screw is placed, just below the
Dr. Itzas, we are losing your voice.
arch of the C1. Now it's clear?
Yeah, it's clear, but we lost your voice for last 30 seconds.
So should I repeat?
Yeah.
Which one should I repeat? Yes, please. From which point should I repeat?
I did not hear anything that you said for the last 30 seconds. It was completely broken.
Okay, I said that Goel says we have discussed the C1 screw, but C1 screw, there are 2 points. One over the direct at the level mid of the posterior C1 arch. Second, that we are not directly placing the screw over C1 arch. Just below to the C1 arch, lower part of C1 arch will be ronged and then put the screw in the lateral mouth of C1. Second is that in C2, we have three options. First option, that is the transpedicular screw. Second option, that is the C2 lateral screws. And third option, that we have the translaminar screws are there. Okay. So these are three options in C2. Most likely, that is the option that is being used, that is transpedicular and lateral mass screws. Okay. Now clear?
Yes, sir.
Now it's clear? Hello,
Yes.
am
Yes, sir.
I audible?
Yes, you are audible.
So how will, okay. So these are three options. This is same. The placement technique of C2 screw will be same as that of the transarticular screws in the Goel, in the Magriel technique. Just the direction will be different because the Magriel is directly going upward superiorly towards the facet joints, and the direction will be different in the transpedicular screws. So what will be the direction of transpedicular screws? This is the point. This is the point. Look at here. This will be your trajectory. Trajectory will be same. You can see this, not trajectory, sorry. The entry point will be same of C21 screws at the mid of the line of the lateral masses over there. Then we will make a burr with the help of drill, about 2 mm burr. Then we will place our trajectory. How we are the transpedicular. We are doing the transpedicular. So this is entry point. We are entering from here. Okay. But we will go because the pedicle, and this will be the lateral mass. Here will be the lateral mass. And here will the pedicle. Okay. And here will be the odontoid point. So our target is this one. So when we are entering point at this one, this is the entry point, but it's not trajectory. So how will you go trajectory? That is about we have to change the direction. I have to change the color. The direction will be changed. That is about 30 to 45 degree. Then we can go up to here. Okay. This will be our direction. Got it? 35 to 45 degree will be there towards the pedicle. Am I clear? Am I clear? Am I audible?
You are
Yes, sir.
audible.
Yes.
I have no idea why they have gone absolutely silent.
Yes, sir. Clear.
Entry point is same. Just when we are going pedicle screws, our trajectory will be different. The trajectory will be towards going to the medial side. What will the angulation? The angulation will be 30 to 45 degree. Then we will go to the pedicle. With the help of C-arm, we will see that we shouldn't enter into the odontoid. Just into the pedicle. When the pedicle is being reached, then we have to stop and then fixed. After that, what is doing? After doing this one bilaterally, the Goel is doing fixation. That is called with the help of rods. Okay. These screws. This is C1 screw that has been placed at the lateral masses just below the C1R. These are C1 is, look at here, this two screw with the help of rod is being fixed. So this is the Goel technique. Second thing is that now Goel is saying that when you are doing this one, it will not help a lot because there is a restricted movement will be there. So what should we do? There are two options. Now fusion technique is there. This is fixation. What's mean by fusion? That you have to put a graft. Then there it is two options. The Goel has two options. The one is that either you have to put a graft after the spinous process, the lamina will be removed and put a graft there. We have two options. This is graft that has been put it. Okay, this is one option. After putting this graft, you have to also tie this one or the hold this one with the wire. It's a because it should be fixed properly. Like this, one wire below bilaterally in each rods, then fix. But this is not the ideal technique of Goel. What is the ideal technique of Goel? This is the ideal technique of Goel. The Goel says that after fixation is that fixation of that one, you have to break these joints. That is called the transarticular joints. These the facet joints. Break that joint after fixation. That put a spacer over there. Either a spacer could be the artificial, autograft could be there, a bone could be there. Okay, put a graft there, then it is called the fusion. When is the fusion? That is when you are doing the grafter there. At second, the articular that is called the intra-articular fusion technique. That is called, and first one that is called the extra-articular fusion technique is there. In intra-articular, intraosseous, that means the facet joint will be disturbed, or you can say the fractured, then put a spacer over there and the rods, with the help of rods you can use. So this is the Goel technique, this one. So Goel technique, 2 rods, 4 screws, C1, C2 separately, and multiple options in C21, because you can pass with the help of in the pedicle screw, you can pass in the lateral mass screws, you can pass in the lamina. What is the advantage of this one? The patient mobility is more preserved as compared to the transarticular. There is a less chances of you can say there is less chances of vertebral artery injury in the Goel technique as compared to the Magrel one. Okay, so this is C2. This is pedicle. Look at here, the trajectory. That entry point is midline of this one. Then we'll go medially about 30 to 45 degree. And this is a lateral mass screw. You have to go, there is no any direction that should be changed. Go directly and superiorly above. Okay. So this is the same. That is the midpoint of pars. You have to enter this one while you are doing you can say the lateral mass screws. Okay, it is just little bit lateral. This is again the lateral mass screws, 2 mm drill, then place directly. This is the angulation what I told. Yes, Dr.
We are running late. We are running really, really late.
Just 1 minute, please. So
Okay.
line, because I started late, and then 30 to 45 degree we have to go medially, then it will be up to the pedicle of this one. So this is the trajectory of this one. Thank you. If you want a step-by-step dissection, then we can do, but actually I avoided this one because the section is same. Just we have to open all the posterior elements till that the lateral mass is. One thing that should be careful that here is a lot of bleeding of the venous bleeding and the C2 ganglion. Otherwise, there will be same. Most likely, we spare the C2 ganglion, but sometimes if you are compromising the C2 ganglion, then you can. If it is incidentally compromised, it's okay. Don't be worried. Just will be there little bit type of the anesthesia, as paresthesia will be there. Otherwise, the patient will be okay. There will be no neurological deficit. And second thing, when we are going to periosteal dissection in the C2 arch, posterior C1 arch, the posterior arch, then we have to be careful while dissecting the periosteal dissection of this one, while we are finding the lateral masses there. So otherwise, there's no any separate exposure points in the C1, C2. If you people need that, how we are going to step by steps, we can take in the next class when we'll discuss other craniovertebral junction approaches. We will also go into the step by step surgical points. Okay, and all the steps. So, any question up to here? No question. Or if you want that there's a lot of still the need to repetition, then we can do the repetition. No better, like the brain stem. We can review it again. If you people need, just tell me.
I think they have all gone on a permanent mute because it's the last session before Eid.
Mustafa,
Maybe
are you
we can.
there?
Yes, he is there. Maybe we can leave
Mustafa,
a
are you
poll on
there?
the group.
Yes, sir.
Yes,
Yes, sir.
Dr.
I'm here.
Mustafa is there.
Yes,
Dr.
sir.
San, are you there?
Yes, sir.
Dr. John, Kingsley,
Yes, sir.
Yusra, Javeria, Why are you so silent?
Yes, sir.
It's
Why are you
complex.
so silent? Just give me response. Uh, if you need the revision of this one, then we can separately again we will revise it and step by step that how we are going surgical steps associated. If no need, then we will proceed for further. That is the uh, occipitocervical fusion and odontoid compression screws.
If you guys want a review, you
What
can
you
just
say?
leave a small message on the group, or maybe I'll put up a poll for the review, and we can schedule a review section right after Eid. Because I understand that this is a slightly difficult topic, not really difficult, but still, and a lot of residents have a problem in remembering this. So just leave us some feedback on the group, and we'll get back to it, inshallah.
All right.
Okay, everyone. So this is a wrap for today's session. Have a really, really good Eid, inshallah, inshallah. And thank you, Dr. Itzaz, for taking out so much time. Let's see about the review session. I'll put up a poll on the group, inshallah.
Yes,
So
put
much.
it on the poll if they need, and then we will go for the all steps from skin to skin, and then we will cover it. If they don't need, then again we will cover the OC fusion and odontoid compression screws.
Yeah, then we can just move to the OC fusion, inshallah. Okay, this is a
Inshallah.
wrap. Thank you so much.